Okay. So this is the title of this case is Too Young for Anterior Wall MI. So he's a 41 years old with no significant past medical history, but he presented with confusion and short-term memory loss, and his vital signs and exam was benign on admission. Social history is very interesting. So he consumes very high doses of caffeine, up to 1,500 milligram of caffeine daily. He gets testosterone injection, and he gets a lot of protein oral intake. He's an avid athlete. He's a weightlifter. He focuses more on the upper body mass. He doesn't smoke, use alcohol, or use any other drugs. When he presented, he had creatinine of 1.5, which is expected with his body mass and muscle mass. Troponin I increased from 0 to 0.6 to 0.21, and this is the traditional troponin I. It's not the high sensitive troponin. His testosterone level was 2500 nanogram per deciliter, and our normative value in our lab is less than 800. This is the echo, shows moderate to severe reduced LVEF with apical akinesis, and we also see this large mass with a highly mobile tip that's consistent with the thrombus. Contrast echo added to our clinical vignette that the distal inferior septum doesn't actually perfuse as well along with the apex, and confirm that this is a thrombus. This is his left heart catheterization, starting from the LAD. As you guys can see, the LAD has a little bit slower perfusion than you want. LCX looks completely normal. The repeat shots of the LAD shows us normal perfusion and normal flow, and the RCA looked normal as well. So these are the MRI pictures. This is the 4-chamber view. Shows us this mass, which is consistent again with thrombus. And this is the 3-chamber view. As you guys can see, this dark of the distal anterior septal and apical walls, and the apex and the mass. So late gadolinium enhancement pictures. We can see clearly that the late GAD starts actually earlier, like probably close to the prox LAD territory, and it's transmural in the anterior septum and anterior wall. And see this dark and filling defect here? So this is actually the thrombus that starts close to the mid to even basal myocardium and extends all the way to the apex. This is the 2-chamber view that shows the same anterior wall, apex is all scarred out or has acute tissue edema, and the thrombus starts all the way to in the mid myocardium, extends all the way to the distal myocardium and in the apex. So this case was diagnosed with a coronary event, either coronary dissection or vasospasm or embolic phenomenon. Patient did not have a repeat cath, which we offered. We started him on medications that included anticoagulation, guideline-directed medical therapy. Repeat echocardiography in 3 months showed EF persistently less than 35%. So patient ended up with an ICD. Patient was strongly advised to stop consumption of caffeine and testosterone, and decrease his exercise and weightlifting activities. That's all the follow-ups that we have, and I'm open for questions.